Emotions, mood and affect are critical elements of the human experience in that they shape and reflect our perceptions of and interactions with the world around us. Emotions, an individual's feeling responses to a wide variety of stimuli. It is reactionary and linked to a specific event or object that can be identified by the person. Mood, an enduring state of mind rather than a discrete reaction, it can shape a person's general expectations about the future. Moods do not produce observable physiological reactions. Affect, an individual's automatic reaction to an event or situation, the immediate, observable expression of mood. Akathisia, state of agitation, distress, and restlessness that is an occasional side effect of antipsychotic and antidepressant drugs. This is the constant need to move around. Catatonia, stuck in a specific position, and it's called this waxy flexibility, inability to move normally, and behavior arising from a disturbed mental state, staying still, fast or strange movements, lack of speech, etc., exaggerated speech or exaggerated movements. It can also be a very exaggerated state where the person can be agitated or be compact, competitive, or impulsive. So I want you to think of Cantonian, both those really exaggerated and really really decline to increase movement. In speech, we're going to take their blood pressure, okay, and you moved their arm for them, and then they stayed in that position for prolonged period of time. That's also a form of catatonic movements. Anhedonia, inability to feel pleasure. Delusions, a belief or altered reality that is persistently held despite evidence or agreement to the contrary, generally in reference to a mental disorder. Delusions are very bizarre, are altered thoughts or beliefs. I think I got drugged last night, or I'm being spied on by the government. Persecution delusion, harm by others, worry about safety. Reference delusion, think everything is referring to you, song, TV. Grandeur delusion, think you're the best and have like superpowers and shit hallucinations, sensory experiences that appear real but are created by your mind. Hear a voice or see something that no one sees, experiencing altered perceptions, smelling their seeing their feeling, not actually real, commanding hallucinations, commanding them to do something. Those are dangerous, right? So that's when we want to make sure that the patient and others around them are safe. Echocholia, meaningless repetition of another person's spoken words. Echopraxia, copying someone's movements. Extrapyramidal side effects, drug-induced movement disorders caused by certain antipsychotics and other drugs. I.E. Tardive dyskinesia, neck first generation / conventional antipsychotics. Chlorpromazine, thorazine. Thioridazine, Mellaril. Flufenazine, Prolixin. Haloperidol, Haldol. Pseudoparkinsonism, adverse effect of drugs that cause symptoms resembling Parkinsonism such as tremor, mask-like facies, drooling, rigidity, and stiff gait. Psychosis, a severe mental disorder in which thought and emotions are so impaired that contact is lost with external reality. 1. Delusions, 2. Hallucinations, and 3. Disorganized thinking. Sometimes we'll see them actually like 4. Rapid fight thought processes. They could have those catatonic movements. 5. Catatonia, abnormalities in 5 different areas that cause these symptoms. So a psychotic break, right? It's like a mixture of everything. Dystonia, involuntary repetitive movement, twisting movements. What happens with that is that they could be lip smacking, it's protruding their tongue, they could be moving their limbs or their trunks, so it's not necessarily difficulty moving, but it's contractions that are repetitive. Acute dystonia, it can involve their neck, contracted in a movement, twisted neck airway. IM/for diphenhydramine, Benadryl, help to counteract this effect. Okay, we would also consider lowering the medication or discontinue it altogether and start on a new one. Tardive dyskinesia / side effect of antipsychotic medications. Stiff jerky movements of your face and body that you can't control. I.E. eye blinking, sticking your tongue out, waving your arms without meaning to. Treat with cogentin, benztropine / decrease or switch meds can be permanent, and it develops after patients taking antipsychotics for a longer period of time. We do all it can happen at the beginning as well, so we do want to do that abnormal involuntary movement scale to really see where they're at, what's their baseline, and then what's happening. Then we can try and cogentin or benztropine to try to stop that movement. So the symptoms basically in the question reflect tardive dyskinesia. So tardive dyskinesia is irreversible side effects of the ingesting products, and the nurse should be calling the doctor to basically avoid, permanent damage. We want to make sure that it's okay to take the drug for the patient and not just, automatically give it to them. Facial twitching and the involuntary movements, and that's what this patient has have. So that's why you would want to hold the doctor. Keep saying that hold the medication, called the doctor, and just make sure it's okay to take it. Word salad, unintelligent, extremely disorganized speech or writing as a manifestation of a mental disorder. Basically putting a bunch of words in a bowl of salad that don't make sense. Ida. Yesterday dogs when I got ice cream didn't do that. Risk factors. Economic/social factors such as rapid changes, stressful work conditions, and isolation. Unhealthy lifestyle choices such as sedentary lifestyle or substance abuse. Exposure to violence, such as being a victim of child abuse. Personality factors. Spiritual factors. Cultural factors. Changes or impairments in the structure and function of the neurosystem, cerebral abnormalities. Psychosocial developmental level and issues. Genetics. Neurochemical transmitters, abnormalities in the brain that can cause these changes in mood and affect. We talk about neurotransmitters like dopamine. Assessment. Determine mental ability of patient and complete health history. Past medical treatment for mental health. Past counseling services. Family HX of mental disorders. Ability to carry out ADLs. Substance abuse. Current stressors in life. Suicidal ideations/attempts *. If patient can't sit through full assessment, have family member present, psychiatric ward, may not be able to because they may have altered thought processes, so then we'll talk to their healthcare proxy. Examination, inconsistent orientation, concentration, posture, level of anxiety, level of appropriateness, label behaviors, inappropriate dressing, cold weather clothes worn in the summer, abnormal speech, observe thought process, identify suicidal tendencies *. Abnormal Involuntary Movement Scale, AIMS. Definition. The Abnormal Involuntary Movement Scale, AIMS, is a rating scale that was designed in the 1970s to measure involuntary movements known as tardive dyskinesia, TD. TD is a disorder that sometimes develops as a side effect of long-term treatment with neuroleptic, antipsychotic medications. Exemplar, schizophrenia, complex brain disorder that affects thinking, language, emotion, social behaviors, odd bizarre behavior and the ability to perceive reality correctly. They don't act normal, they don't think normal, they don't talk normal. Syndrome or disease process with many different varieties and symptoms as noted in the DSM-5 criteria. Schizophrenia DSM-5 for 6 months, 2 or more characteristics must be present for at least a 1-month period, and they must last for 6 months, and then it's going to get your diagnosis of schizophrenia. Exact cause is unknown, can be a combo of genetic, biological influencer, cultural, and psychological factors. Many live successfully in the community. Diagnosed in late adolescence or early adulthood *. Peak onset is 15 to 25 men, 25 to 35 women. Schizoaffective disorder, diagnosed when the client is severely ill and has a mixture or psychotic and mood symptoms, also depressive and bipolar, so they could have a mixture of those two different mood disorders. Clinical manifestations. Hard symptoms, positive. Delusions. Hallucinations. Psychosis, depersonalization/derealization. Grossly disorganized thinking, speech, and behavior. Flight of ideas. Echopraxia/echolalia, catatonia. Clang association, rhyming words. Word salad. Ambivalence, mixed feelings. Perseveration. Soft symptoms, negative. Flat effect. Avolition, lack of motivation, putting off tasks. Social withdrawal or discomfort. Anhedonia, lack of pleasure. Apathy, lack of mood or enthusiasm. Blunted effect, difficulty expressing emotions asterisk. Inattention/poor concentration. Cognitive symptoms, memory deficits, poor attention, concrete thinking. Schizophrenia types. 1. Paranoid, strong irrational suspicion with dominant symptoms of delusions and hallucinations. If a client sees the nurse is talking with a psychiatrist, they may believe it's about them. 2. Disorganized, most socially impaired form. Dominant symptoms of disorganized speech and behavior as well as inappropriate affect. Bizarre mannerisms, poor hygiene, constant muttering to oneself, often found in homeless population asterisk. 3. Catatonic, abnormal levels of motor behavior, either extreme motor agitation or retardation. Withdrawn, mute, refuse to participate in activities, versus hyperactive behavior, talk, shout continually. Schizophrenia pharmacology. Treat the symptoms, anti-anxiety medications, antidepressants, so let those SSRI that can cause that serotonin syndrome and mood stabilizers, but our first line of treatment, what we try first is this antipsychotics. First gen/conventional antipsychotics, used to treat positive symptoms of schizophrenia asterisk. Chlorpromazine, thorazine. Thiordazine, Mellaril. Flufenazine, Prolixin. Haloperidol, Haldol, hook them up to an EKG. Asterisk, more harsh med, first gens. Increases likelihood of NMS/EPS extrapyramidal symptoms. Complications, extrapyramidal side effects, anticholinergic effects, neuroendocrine effects, seizures, skin effects, orthostatic hypotension, agranulocytosis, dysrhythmias, neuroleptic, malignant syndrome, anticholinergic effects. Orthostatic hypotension, dry mouth, suggest SF hard candy or gum, 2 to 3 L fluid, give foods high in fiber, up fluid, stool softener, raw fruits and veggies, grains, lower than 1500 is a fluid restriction. Constipation/urinary retention, can't pee, stool. Dry mouth. Flushed skin, but not sweating. Very dry. Can't see. Blurred vision. Photophobia, wear sunglasses outside. We can. Suggest SF hard candy or gum. Sips of fluid. 2 to 3 L fluid, give foods high in fiber, up fluid, stool softener, raw fruits and veggies, grains. Wear sunglasses outside. Report temp, NMS, neuroleptic malignant syndrome, life-threatening NMS, fever, altered mental status, AMS, encephalopathy, confusion, mental status changes. Leukocytosis, tremors, elevated CPK, rigidity, HR up, T up, BP up or down, RR up, antipsychotic, 2 to 20 days ago, F fever. E encephalopathy, confusion, mental status changes. V vital sign instability, tachycardia, tachypnea, and or high label blood pressure. E enzyme elevation, up creatinine phosphokinase, CPK, increased because of rhabdomyolysis, because muscle breakdown. Our rhabdomyolysis, caused by muscular rigidity, distinguishes NMS from other toxidromes like serotonin syndrome and anticholinergic toxicity. Our rigidity, generalized lead pipe muscle rigidity. Agranulocytosis, monitor S/S of infection. Low WBC granulocytosis occurs when there are too many granulocytes/a type of white blood cell in your blood. It's a symptom of many different conditions, including infections. Extrapyramidal symptoms, pseudo-Parkinsonism, tardive dyskinesia, akathisia, inability to sit still, acute dystonia, life-threatening in the neck, difficulty swallowing, sort of acute muscular rigidity or cramping, but specifically if it has to involve the airway, what medication? 4 or IM diphenhydramine, brand name, Benadryl. Treat EPS with cogentin and benztropine, clonazepam, benzodiazepine, and or lower the dose or change meds. Tardive dyskinesia, they develop facial tics like lip smacking, tongue thrusting, and rapid blinking. Asterisk with all antipsychotics you start at lowest dose and work your way up until you have reached the therapeutic blood level to decrease the risk of any of these side effects. Second generation / atypical antipsychotics, you're atypical. Treat positive and negative symptoms. Helps decrease bizarre behaviors and depressive symptoms. Olanzapine, Zyprexa. Risperidone, Risperdal. Quetiapine, Seroquel. Aripiprazole, Abilify. With second-generation antipsychotics, atypical, you have increased risk for metabolic syndrome and less likely for NMS/EPS because they are atypical. Be aware of what you're eating, increased risk for cardiovascular complications, neurovascular complications, renal complications, and your weight. Complications: long-term risk metabolic syndrome, hyperglycemia, hypertension, and high lipids, long-term cause them to have a heart attack or stroke. Increased cardiovascular risk, weight gain, healthy heart, healthy diet, workaholic, increased fiber, make sure that they have some regular exercise, hyperlipidemia, agitation, dizziness, sedation, sleep disturbances, lower risk for EPS, anticholinergic effects, and NMS. Education for all antipsychotics. Suicide for both and safety risk. They can take 4-6W to be effective. Don't stop abruptly, both. Monitor for metabolic syndrome, more second-gen weight gain, can't control glucose, high BP, high lipids, risk for cardiac issues, stroke, heart attack, diabetes. Schizophrenia nursing considerations. Assess suicide and safety risks. Schizophrenic population, 20 to 40% of them attempt suicide. Safe, secure, MIWI environment, therapeutic, and structured, helps to decrease anxiety, decrease delusions and hallucinations, then just really build trust. Establish a trusting relationship. Avoid direct questions. Client may feel threatened. Client may feel threatened. Are you planning on hurting yourself? Are you planning on hurting somebody else? That's when there's a direct question. Maintain therapeutic, objective, clear, concise communication. Calm tone, address client by name. Observe for early S/S of escalating behavior. They're experiencing it, and it may be true to them, but it's not actually happening. What you're seeing, or seeing things in the room, is making you afraid. However, I want to let you know that I'm not seeing them. Okay, so we still need to present reality to these patients. Tolerate silences. Client may be too anxious to speak. Silence is a great therapeutic technique actually, and especially when you're first developing your relationship with the patient. They don't know you, they don't want to share with you, and so they may just sit there, and just knowing that somebody is there with them could help a lot. Reduce stimulation. Provide solitary activities, stuff you can do alone, reading. Until they are able to participate in group activities, they don't really have any external stimulus, but delusions do, and so if we have TV that's really loud, it can either cause delusions or anxiety. Provide simple activities or one that promotes self-esteem. Finger painting, clay, art therapy. Avoid competitive activities. **** Milieu therapy is a safe, structured, group treatment method for mental health issues. It involves using everyday activities and a conditioned environment to help people with interaction in community settings. Milieu therapy is a flexible treatment intervention that may work together with other treatment methods. Cognitive behavior therapy. Cognitive behavior, brain and action. Okay, so helps to change the way that they think about something, perceive something. A lot of times people who benefit from cognitive behavioral therapy take something and actually end up internalizing it, changing it. Works on their their thought process, and then what happens, because of that thought process, their behavior helps them to modify their behavior. All these symptoms that are happening, that's really interfering with them, they will also have to be on medication. Exemplar. Bipolar disorder, go from one stage to the next. Very happy, sad, hopeless, down. XXXXX. Bipolar disorder I, mood disorder characterized by at least 1 week-long manic episode. Manic episode may alternate with depression, some sort of remission. Bipolar disorder 2, low-level mania alterations with profound depression, less manic. Risk factors. Neurochemical risk factors, serotonin plus norepinephrine. Hormonal fluctuations. Genetics, 10x more likely. Psychological stressors. More common in highly educated individuals. First manic episode usually occurs between teenage 30 years. Young men in early onset of illness equals highest risk for suicide. Bipolar clinical manifestations. Manic/mania, happy, energized. Depressive, down, depressed. Begin suddenly. Escalation of symptoms over course a few days, lasting weeks. Euphoria, heightened, grandiose mood. Attention-seeking behavior. Agitation, increased emotion. Exaggerated self-esteem, goes W grandiose mood. Sleeplessness, prob not taking care of themselves. Pressured speech, increased talking, talking fast with urgency, go off on tangents. Flight of ideas. High-risk activities, poor judgment, impulsivity, a lot of suicide risk. Increased energy. Possible presence of hallucinations or delusions untouchable right, so they could have take high risks of hurting themselves. They could have increased energy and possible presence of hallucinations or delusions. Gradual slide into depressive state. May last weeks to months. Flat, blunted effect. Tearfulness/crying. Inertia, lack of energy. Anhedonia, lack of pleasure. Difficulty concentrating, focusing. Self-destructive behavior, impulsiveness, but you know they could be in suicidal tendencies with depression. Decreased appetite. Disturbed sleep, could be insomnia or could be prolonged periods of sleeping. Psychomotor agitation/retardation. Bipolar disorder pharmacology helps to smooth out those highs and lows. Very effective for risk of suicide in patients that it really helps to decrease at risk. However, and if it's not because it had that very narrow window of being helpful to the patient with still monitoring for suicide, it can also cause orthostatic hypertension of the patients not getting enough fluid. Okay, we want to make sure that they know their plan to go and get their blood drawn and why they're getting their blood drawn. Avoid alcohol. They don't stop taking the medication abruptly unless they're ordered to because of toxicity. It can take about 3 weeks for looking to really reach a therapeutic level, possibly even more. Lithium, therapeutic level 0.6 to 1.2 milliequivalent/L, becomes toxic 1.2 milliequivalent. Takes a few weeks to kick in, might be put on anticonvulsant/antipsychotic in the meantime. Mood stabilizer if all of a sudden the patient's not getting enough medication, if their therapeutic level's going down, if they're not getting enough medication, we're going to see signs of mania. Toxicity, N/V, abdominal pain, lethargy/confusion, muscles weakness/tremors, slurred speech, increased U/O, convulsions, ataxia, drunk looking. Diet considerations, continue to eat salt. Salt risk for toxicity, getting enough salt. I want them to have at least 2 grams sodium a day, but not big huge jumps in their intake, nothing to be like too extreme or too little, but basically that they need to stay on the same amount and enough fluid, at least 2 to 3 liters of water a day. Daily weights, strict INO. Monitor for fluid overload, but also fluid deficit, because remember I said they need to have adequate liquids and salt to maintain their lithium therapeutic levels. Weekly therapeutic level check, labs frequently. Take med same time every day. Don't stop taking the medication abruptly unless they're ordered to because of toxicity. No alcohol. Toxicity, 1.5 to 2.0, blurred vision, ataxia, tinnitus, persistent N/V/D 2.0 to 3.5, excessive output of dilute urine, tremors, muscular irritability, psychomotor retardation, confusion greater than 3.5, impaired consciousness, nystagmus seizures, coma, oliguria/anuria, arrhythmias, myocardial infarction 2.0 is when it's really deadly. Okay, like we're starting to get deadly, we have too much sodium in our system, we have some muscular irritability, and then when it gets above 3.5, that's when we have a risk for coma arrhythmias, so we really want to keep it below that 1.2. Not be a good candidate for lithium. heart failure patients, kidney patients, okay, anybody who has to avoid large amounts of fluid or large amounts of salt, okay, so yes, good, anybody who's at risk for dehydration should not take lithium. Lithium is almost like sodium in the body. So dehydration can cause lithium toxicity. So the patient needs to stay wide hydrated. They want to make sure that if they're sick and vomiting, or if they have excessive urine output. So if they're on diuretics, that they're taking extra fluid in to make sure to prevent lithium toxicity. And then D, I should take the medication with food. So, that is correct. Take lithium with food to decrease any type of GI upset. Anticonvulsants, aka mood stabilizers, can be given in conjunction with lithium to decrease the amount of lithium needed. Carbamazepine, Tegretol therapeutic level for -12 mcg/ml. Bone marrow suppression, signs infection, anemia CBC, and thrombocytopenia, low platelet count. When we get that to a patient that has seizures, what is the normal therapeutic level? 50-100. Valproic acid, Depakote therapeutic level 50-120 mcg/ml for mania. Side effects, photosensitivity, hepatotoxicity, bone marrow suppression. Monitor for liver enzymes *. Point may complain of RUQ pain, nausea, anorexia, fatigue, jaundice, yellow squares, so their eyes, jaundice, skin. I'm gonna look for anorexia, some nausea and vomiting, some fatigue, but looks for some abdominal pain, so, and then I'm going to look at my ALTCAs that can tell us about the hepatotoxicity. Monitor for bone marrow suppression, CBC, low platelets. Antipsychotics. SSRI antidepressant. Monitor for serotonin syndrome. Sertraline, fluoxetine. S/E of SSRIs, weight gain, orthostatic hypotension, decreased libido, increased risk for GI bleed, suicidal ideation *. Avoid alcohol and OTC drugs. Tell provider, do not stop abruptly. SSRI antidepressants, when you have your patient deaths, depressed, right, very low mood, don't want to eat, don't want to do anything, but they have suicidal ideations, they have more energy, right, they have clear mind, clear focus, and now they could actually carry out their plan, because a lot of the times, unless we have that there be in the background, their suicidal ideations aren't going to go away, right, so we want to make sure that they're taking the medication, we're still monitoring them. For suicidal ideations, or attempts, cognitive behavioral therapy. Dialectical behavioral therapy, DBT. This is why I feel sad. Let's use some tools to not feel sad anymore, but I'm okay, I'm already being sad, and then change your behavior versus something that becomes overwhelming, and you let it take over, and you become impulsive, okay, so it teaches you to be okay with the emotional state that you're in. Serotonin syndrome. Shivering, neuromuscular symptom that is unique to serotonin syndrome. Hyperreflexia and myoclonus, seen in mild to moderate cases. Most prominent in the lower extremities. This can help differentiate from neuroleptic malignant syndrome, which would present with lead pipe rigidity. Increased temperature, not always present, but usually observed in more severe cases, 41C. Vital sign abnormalities / instability, tachycardia, tachypnea, and labile blood pressure, up or down. Encephalopathy, mental status changes such as agitation, delirium, and confusion. Restlessness, common due to excess serotonin activity. Sweating, diaphoresis, autonomic response to excess serotonin. This symptom can help differentiate from anticholinergic toxicity, in which the patients would present with increased temperature but dry to the touch. 1. Withhold med. 2. Stabilize vitals. 3. Cardiac monitoring. 4. IVF. 5. Supportive care. 602 admin. 7. Clonazepam, benzodiazepine for sedation. Electroconvulsive therapy for bipolar, ECT, try meds first *. A treatment procedure that passes an electrical current through the brain to induce a seizure. Usually given 2 to 3 weekly, for 3 to 4 weeks until a course of 6 to 12 treatments is completed. In total 12 treatments. ECT takes approximately 2 to 3 months to reach desired effect. Effective in treating depression, increases serotonin and norepinephrine. Associated with improved mood, functional status, anxiety, and quality of life. Especially used for patients with severe depression who are resistant to other treatments, who are severely suicidal, and for those with severe psychomotor retardation. Connect to EEG to monitor brain, and EKG for heart monitoring. If patient is on Ativan, hold or decrease it because it's an anti-seizure med. Prior to ECT, medical history, physical exam, mental health assessment. Blood work, ECG. Pre-procedure. Anesthesia. Make sure that the patient is under some general anesthesia, so they're able to answer questions. Informed consent could also be court-ordered, not have to be the point herself. Because they don't have capacity to make their own decisions right now, they may not be able to, so we can have the healthcare proxy do it or the court may order it. NPO at MN. Void prior to start. Hold clonazepam, benzodiazepine, or anti-seizure/anticonvulsant may interact with the seizure activity on muscle relaxants, right relaxants, because we need that seizure activity to occur. IV access. Remove dentures, contacts, jewelry. During procedure. Ambu bag/airway. Bite block, SZ. Vital signs. Post-procedure. Monitor gag reflex/mental status after sedation/paralytics. Mild confusion/temporary short-term memory loss common. Short-term memory loss should go away, should be just that short-term memory, so they don't really remember the procedure, so this will trauma. Headache. May feel tired or report muscle aches. Recover in a lateral recumbent position to prevent aspiration. Patient should not drive for the remainder of the day and should have someone with them. Bipolar disorder, nursing considerations. Provide for patient's safety and those around, shoestrings or strings for their pants or their sweatshirts. Assess suicidal tendencies. Decrease stimulation, milieu environment, seclusion, room by themselves. Limit setting, if applicable, don't allow manipulation. Monitor for escalating behavior. Calm, matter-of-fact communication. Seclusion may be someone trying to harm themselves or others. Restraints if they're acting towards harming others. Consistency of staff members * follow that schedule with them too. Set limits, so we want to set boundaries and limits. If you do this is what will happen. It's dark form of punishment, but it's a form of consequences, right? Because they have that impulsivity, the attention-seeking behavior. It also helps them build trust with the nerves in the all staff splitting behaviors in bipolar disorder. Splitting of staff, so it's usually when someone is trying to take advantage of the situation, right? So if you have a consistency of staff members, it helps. It's beneficial for the patient several different ways, helps them not to really, it's more, we'll see it more for our personality disorders, but in general it's good to do because it builds trust. Make sure that communication stays the same, that's consistent, that they know that they can't push any boundaries. And get away with things. Diet of finger foods, high calorie, more so for mania when they're on the run, and protein encourage nutrition and eating. Safety especially during manic state. Can do CBT and DBT, CBT, cognitive behavioral therapy, and DBT, dialectical behavior therapy, group therapy, family therapy. There's tons of therapies, electroconvulsive therapy, and it's not actual like psychological therapy, it's more of a treatment, someone whose matter-of-fact is straightforward and unemotional. Your matter-of-fact friend won't get upset when her dog runs away, she'll call him calmly until he returns. Matter-of-fact things aren't fancy or stylish, they just tell it like it is. Can give those medications to patients who have heart failure, diabetes. Second-generation herbal remedies.